we must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hello, everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm one of your hosts, and my name is Brandon Pollen, and I'm joined by my fellow co-host, Stephanie Wyrock. And today we welcome Dr. Ola Grimsby, who is the Chief Consultant and sole proprietor of the Ola Grimsby Institute. And for those of you who don't know, he was Norway's first executive member of IFOMS and a founding member of the American Academy of Orthopedic Manual Physical Therapy. Dr. Grimsby established degree-granting authority for the Ola Grimsby Institute residency programs, offering a Doctor of Manual Therapy degree, as well as a PhD. Now, Ola, first and foremost, thank you so much for your service and dedication to the profession throughout your career. And, I realize, of course, that you've done much more throughout your career than I had just mentioned, but, would you mind giving our listeners some background into who you are and about your journey as a therapist to forming the Institute to kind of where you're at now?
Hi, Brandon, and thank you for having me. My background is, as you may hear, from Norway. I was trained as a physical therapist in Norway and at the Department of Health in Oslo, Norway. And then I had a 4-year post-secondary study in manual therapy. In those days, it took actually 4 years, so a kind of a combination between residency and fellowship, I guess, to graduate from our program. Following my manual therapy education, I started clinical work in Kristiansand, Norway, where I, over the next 10 years, developed 2 clinics and started to take students to teach manual therapy. I became an instructor with the International Seminar School, teaching with James Sirius and with Fredrik Altenborn, Olaf Evient, and this group of instructors. And then later on, I was invited to come to be the principal instructor of the Institute of Post-Secondary Physical Therapy, working with Stanley Paris for a year or so here in the US. Then that was over. I went back to Norway and started to take students from all over the world in my clinics in Norway. And they continued that until the Norwegian immigration laws changed. They no longer wanted to have open borders for physical therapists, or not even for Americans. So the last student I had was a very good friend of mine, instructor of the OGI, who was actually deported. And I was threatened to be thrown in jail if I don't stop bringing in Americans to Norway. Very strict rules. So anyway, the consequence of all this was that in 89, I went back to the US and started the Ola Grimsby Institute. And that's basically the short version of a long life. I'm 77 years old. I have been retired for 5 years. And I can tell you a lot of fun stories from the last 45 years of practicing manual therapy.
Wow, I can't believe that they almost threw you in jail for accepting students. That's pretty intense.
I don't think it would actually become a reality, but it was a clear threat at the time. The reason was that Norway opened its borders for refugees from Vietnam, and when that happened during the Vietnam War. And some of the problems we had with integration increased the crime rate and a lot of different problems in Norway. And for that reason, they had to change the immigration laws. And to create a new system, they actually decided to block the borders or block immigration completely for a while. It wasn't like a permanent antagonistic attitude to anyone. It was just in order to reestablish the laws behind immigration.
Well, I know, Ola, you've had a very long seasoned career, and you've done a lot for our profession. So I want to give some background on the scientific therapeutic exercise progressions, or STEP. So let's back up first to talking about Oddvar Holten, who was one of the first in the field of manual physical therapy and created the medical exercise therapy, or MET, with the aim to improve one or several functional properties of utilization of objectively graded activity, and then creating the Holten curve. Do you think that you could expand on MET and what it is and how you transformed it into the scientific therapeutic exercise progressions?
Sure. It was an interesting development. It was about, I think, 15 manual therapists in Norway before I got to be a manual therapist. It was a very small group. And one of my instructors was Oddvar Holten. This group of manual therapists, they sent Oddvar down to Max Planck's Institute in Germany to learn more about exercise physiology. And he brought this back to Norway and developed a program that he called medical exercise therapy. And this was later on recognized by the Department of Health and got its own reimbursement code from the governmental insurance company. So it became financially rewarding to do this. It became also extremely popular for clinical reasons because, as we probably all are aware of, well-documented literature on the effects of exercise therapy. And this was more or less replacing some of the passive role that manual therapy had, at least by reputation. So in Norway, we now developed manual therapy into much, much more than a technique. It was a thorough evaluation with an attempt to create tissue-specific exercises. It was also a development where manual therapy, mobilization and manipulation was initiated and used together with soft tissue work and followed up without exception with rehabilitation exercises. And all of this is what we called manual therapy, and all of this is what took 4 years to learn and to graduate from. So Oddvar Holten was the first one, and this curve that is carrying his name is not all that scientific. It actually happened on a summer day on a sidewalk restaurant in Oslo. It was a group of us, like 6 or 8 instructors. Oddvar only had 8 instructors in his entire career, and I happened to be one of them. So we were sitting there having a sandwich and a glass of beer. And when he had eaten his sandwich, he turned 2 plates around so they kind of came up toward each other into 2 semicircles. One of those semicircles described the percentages of 1RM, and one of them described the number of repetitions you could perform with different degrees of resistance. He looked at how many repetitions and which percentage of 1RM would create what kind of functional quality. Like endurance, vascularity, and so forth was around 60% of 1RM. The coordination would be lower than that. And then you could have fast coordination a little faster than that. And this would go up towards strength and up to power. And this is the Holten curve. It happened after a couple of beers and a sandwich on a sidewalk in Oslo.
I feel like a lot of the greatest things in the profession of physical therapy happen over a beer.
A lot of good things happens over a couple of beers. Yes, I agree.
Oh, that's an awesome story. That totally changes how I look at that now.
Well, it didn't stay quite that amateur, actually. It started to develop a lot of the more extensive research. The most recent one that just came from Jim Rivard, my colleague, and the past academic chief of the OGI and also the president of the American Academy. Together with Rick Kring and Cindy Onsleber, they did some studies on vascular perfusion of blood in tonic muscles, or predominantly tonic muscles. And they did this with laser, and they found out, laser Doppler, and they found out that if you do 60% of 1RM, you actually will have an increase of blood perfusion of 46%. However, if you go up to what most people think is the real main way of doing rehabilitation, increasing strength, then you actually lose blood perfusion. If you go down to about 30-40% of 1RM, then you actually only have like about 25% increase in blood perfusion. So this 60% of 1RM resistance, which allows you to do about 25 to 30 repetitions, is something we do over many sets in high frequency of different groups of muscles related to the rehabilitation as the optimal way of increasing vascularity and consequently metabolism. So research like this is now documenting that what Oddvar Holten not only learned from Max Planck in Germany, but practiced in his life in Norway and followed up by the rest of us, has a lot of documentation today.
That's really, really interesting, Ola. And, after kind of gathering kind of what MET and STEP really, really are, and of course you mentioning that, it's very high frequency based, really looking at vascularity in the tissue as response to exercise, and then saying how it can be a certain percentage of 1RM. How else, besides what you had just mentioned, how else is STEP unique compared to other exercise prescriptive parameters or other exercise schools of thought that perhaps you hadn't mentioned?
Well, first of all, there are so many different schools of thought on exercises. When it comes to rehabilitation, all of this has mainly been guided by physicians' lack of education in rehabilitation. To them, I always got referrals for strengthening exercises. What they did not learn in medical school was that strength is the least interesting thing to gain for a patient in rehabilitation. When you've had pain, either nociceptive or allodynic or whatever kind of pain you may have had, and you have lost coordination because of the guarding and the secondary fear avoidance and all that stuff that happens with it, then what the patients need is vascularity and slow coordination, which will increase with exercises up to fast coordination and a lot of other functional qualities. So the primary thing here is to define the functional quality the patient is in need of. Now, what other schools of thought may teach on this varies a lot. But I have a feeling when I go around teaching this, that the general rule is 30 repetitions if you can overcome it. And then maybe 2 or 3 sets if the patient can do it. There seems to be very little reference to details that STEP represents, like repetitions versus resistance, speed, break, range, set, concentric versus eccentrics, etc., etc. All of this we define individually, and we also try to do this tissue specifically, individually adapted to the patient's pathology. And I don't think that's all commonly done either, but that's just my perception.
What are the key considerations for STEP when it comes to specific tissues? Like cartilage or bone or tendon, ligaments?
That's a very good question. It's a question of histology, though. I mean, we do know that we may not always be able to define the tissue. It's simple enough in the wrist, the hand, the knee, whatever. A lot more complex in the spine and not even always possible. However, you can narrow it down to some extent. And when it comes to things like bone, then we learned a lot from the research done in space. I'm participating in some NASA research. Actually, I'm following up on Jojo Sason's over NASA man on this. And we learned from them that in microgravity here, we're losing bony density. And a lot of research has been done to prevent that from happening. What we have learned is that compression, decompression in the line of stress of the trabecular system in bone is the imperative key. In addition, we learned that not only biomechanical energy, but nutritional energy, of course, is imperative as well. So that's for bone. When it comes to cartilage, we know it is intermittent compression, decompression, along with gliding, which will emphasize the synthesis of the chondrocytes. And of course, when it is a question of collagen, then elasticity and plasticity, the two main components of functional qualities in collagen, they are also facilitated by modified tension in the line of stress, modified by nociceptive responses, tenderness and pain. So in addition to that, we know that, for example, to take one of many examples, absorbable calcium C, calcium citrate, for example, will facilitate the synthesis of collagen connective tissue. There's every tissue has its own kind of optimal biomechanical and nutritional stimuli, and that's what that's the reason for why we try to do the tissue diagnosis. We don't treat muscle the same way as nerves, bone the same way as collagen, cartilage the same way as blood vessels, etc., etc. And if you don't know what the tissue is, then you really don't know what you're doing.
I think that's a really, really interesting point. And you bring up a lot of good things that really give some perspective on this. And, you know, you had mentioned before that all these things can make STEP unique. But, you know, we'd like to play devil's advocate on this show a little bit. So I'm going to ask you, what are some of the limitations of using this type of paradigm?
Well, I would say that all exercises can be extremely dangerous when done incorrectly. I don't really know how I can demonstrate that on the podcast, but let me take an example. When I was 20 years old, I was in a sports school for people who wanted to become professional athletes or coaches and trainers. And I was at the time a high jumper and a pole vault jumper. Now they were interested in my vasti for that reason. So I was also a guinea pig. And I had approximately 500,000 fibers and about, I don't know how many motor neurons I had at the time. But I represented a good average standard for a well-trained person. Today, I'm 70 years old. I have less than 50% of those fibers and those motor neurons in the same muscle. But I still try to do the same amount of work every day as I used to do when I was 20, one of these stupid weekend warriors. And the consequence of that is that I end up with all kinds of trauma. Now, if you then get these overuse syndromes, my age, what do? You go to a physical therapist. What does he do? He gives you exercises. Brilliant. Now, unless that physical therapist knows exactly how to dose my need for repair, then he is a dangerous physical therapist. That's why exercises here can represent a potential danger unless you know how to dose individually and specifically related to tissues. I don't know if that's a good example, but it tells us that you're not actually getting in shape while you're exercising, unless your exercise is performing a certain minimal amount of damage to the tissue. Then you do not have the necessary repair effects, and it is between the exercises that you repair and get back in shape. So limitations are related to lack of dosage. That's not typical for STEP because we do individually dose exercises to avoid that. But in general terms, that's the main danger for using exercise in rehabilitation, I think.
There's a lot of talk, at least among my colleagues, that it's common for physical therapists to underdose exercise. So I think that that's a really important point that you make, Ola. What does the evidence say about STEP compared to other exercise prescription parameters?
I really have no specific references comparing the specificity of STEP with the specificity of others. I have never seen research comparing specific concepts of exercises. We can compare what strength does compared with what endurance, vascularity, coordination does, etc., etc. eccentrics compared with concentrics. That's why in STEP we build this as a slow progression, trying to define exactly what patients are able to perform. I think the best way of answering this is what Oddvar Holten used to say. He said that medical exercise therapy, what he called it in those days, is the art of the possible. So he said it is no difference in the cellular response of the little old patient and an Olympic athlete champion. There is basically the same response. The dosage and the specificity is what's different. And this varies so much from school of thought to school of thought that I have never seen them really compared in all fairness.
That's really interesting. And, gathering, of course, saying about the specificity of the tissue, and of course, how you treat it is going to depend on the type of tissue involved. But let's say, for example, that we're treating a patient and it may not be as much tissue related as we thought. And instead, it might be more of an oversensitive nervous system component of it. So whether that be peripheral or central sensitization, can it be modified for something like that?
That's a very interesting question, yes. And the answer is clearly yes. Now, almost all rehabilitation of patients in pain comes from one or more kinds of nociceptive response initially. Then it may become allogenic. It may be a result of the patient's response to pain. There may be sprouting and changes in the dorsal horn. We may have changes in the H reflex because of the dorsal horn reflex that has like a reversed from afferent to efferent response to the peripheral site, etc., etc. You then have the central sensitization where the brain comes into all this. But all of this is related to the patient's perception of the problem, which brings us right into psychosomatic and psychological aspects of exercises. So how do we modify STEP accordingly? First of all, we wouldn't throw the patient onto a pulley system with heavy weights. Obviously here, that's why we are using dorsal horn inhibition with manual therapy, articulation and mobilization to use inhibitory interneurons in the dorsal horn. When we have inhibited the pain and the guarding and the patient's comfort zone and fear avoidance is taken care of, then we will go on to a dosed exercise. And again, let me quote Oddvar, to have them experience the art of the possible. They might not be able to do anything but rolling over in bed. Okay, so let's roll them over in bed. But the key here is that we take that question into consideration and modify everything accordingly. I don't know if that answered the question. There's a lot more to that, but I don't think we can get into the dorsal horn inhibition concept and central sensitization, although it's a fascinating topic.
No, I think that's really was a great answer because, it's important that we are able to decrease pain before we apply any type of exercise intervention. Otherwise, our patient isn't going to be compliant with their home exercise program.
Exactly. And, that's actually the key to the kind of therapy we do, the fact that the tissue reference will deal with the nociceptive component. The treatment with the hands-on of soft tissue will modify the patient's perception, and the exercise will make it patient become confident in his ability to perform. So we need all of those in order to deal with that specific concept.
Yeah, I totally agree. I think that's a really great point. I want to turn our attention a little bit to residency because I know that the Ola Grimsby residency and fellowship program is something that your institute has started. And here in the United States, we have residency programs that are co-sponsored by APTA. So I'm wondering how your residency or fellowship program compares to other residency and fellowship programs and what the layout of your residency program is.
Well, it has changed a lot over the years. It started with a 4-year clinical and didactic program, which we modified according to the guidelines of the APTA. Today it is like a 1-year residency, a 1-year fellowship, but we could not teach over a 4-year program in 2 years. So we have added a 3rd year where we call it advanced academic competencies, and where we also have the students complete a dissertation, and then they are awarded with a PhD. So all of this is in sequence from the basic residency training, which is learning all the different both didactic and clinical techniques that is necessary to know to perform an optimal approach to what we call manual therapy. Then the fellowship is supposed to be secondary to that, where you learn to apply all these things into a clinical situation with the patients. The problem we have in the US is that as soon as IFANT accepted fellowship as the keyword, the residency programs in the US skipped the residency, and now they teach 1-year fellowships. And the entire idea came from the medical profession, which is based upon a necessary mandatory residency before you get into a fellowship for specialization and clinical competence. So if we were to follow the medical model, if that was the intention, then it should be mandatory to do a residency before you do a fellowship. We can't possibly manage to do everything in a 1-year fellowship. We need to do it over 2 years, and even then we have a lot of multidisciplinary things we'd like to add to that, which will be the 3rd year, followed up with research and a PhD. So that makes our residency maybe slightly different than the others. The other thing that is important for us is that we also have a scholarly component to this, where the student also learn to teach and where they learn to do research. They actually do a research project, and when that's completed and they have done their 150 hours of clinical supervision and mentoring, and they have met all the other accreditation demands, then they get a doctor of manual therapy. Actually, they called it a doctor of physical therapy when we established this way back. But then the APTA decided that they wanted to call graduate students or graduates from PT school, they wanted to call them a doctor of physical therapy. So they wrote me and asked me if I could change my name and leave the DPT to an entry-level doctoral degree, which I agreed to. And we changed it into a doctor of manual therapy, which is a post-secondary degree.
Wow, that is interesting. I never knew that happened before the DPT name was kind of more mainstream. That's really interesting. And it's interesting that, that program really, as you kind of said, it hits many different aspects between not just clinical, but education, research, and then it can morph into a PhD, which I think is really, really good. And that would also help contribute to shortage of, terminal degrees with PTs. But, I'm going to switch gears a little bit here, Ola, and go to, a topic that we've heard from a lot of physiotherapy students. And, my question is, do you feel that graduates from DPT programs overall across the U.S. are adequately prepared in exercise selection and prescription? And if the answer is no, why do you feel that this is the case?
Well, when you travel around the country and around the world, actually, then you see and compare the different programs. When these students come to take step classes or exercise classes from us, then it becomes obvious that their basic education on exercises most commonly is based upon VO2 max, which has absolutely very little to do with peripheral rehabilitation. Of course, oxygen is imperative, so are lungs, but it doesn't help much to have a great VO2 max if you have a tendinitis in your elbow. So what we're talking about here is a completely different approach to treating different sorts of exercise, different sorts of tissues with the optimal stimuli, biomechanically and nutritionally. And that's not known among physical therapists. But you asked me why. Well, physical therapy school entry level is aiming to meet the specialization in other fields of medicine. And that's an enormously tall order. There is no way anyone can be a specialist in all these different areas from the education we have in physical therapy with the amount of time they have to learn all that. So that's why this residency, where you learn basic tracks and specialize in that with a fellowship, is becoming imperative as a part of the continuing education in post-secondary education in manual physical therapy, in all the different aspects of physical therapy, not only manual therapy. I think today we have approximately 120 residency programs in orthopedic manual therapy in the US. When I first came to the US in '89, I wrote to the person in charge of postgraduate education, it was called Continuing Education Office in the APTA, and asked if they would be interested in engaging or cooperating with such a residency approach. We had one already in 1986, and I wanted to bring the APTA along. And the answer I got was that there is no need or interest among the physical therapy profession or population in the US for any such thing. Today, we're about to see a mandatory development of this, and I'm really glad that the APTA is following up on it, and I'm really glad that they're also creating the accreditation, the professional accreditation that they are doing for residency and fellowships.
It sounds like you've done a lot in the realm of residency, and now I do feel like it's a popular thing here in the United States. You know, I'm interested in knowing what solutions you would recommend to improve the integration of exercise prescription into entry-level PT education. Because like I said, a lot of people do say that we underdose exercise.
Yeah, I think we know that the lack of exercising is the entire basis for optimal rehabilitation. I think the reason for the problems we have with patients going out from rehabilitation is that this is not a thing that they can manage to handle in activities of daily living. So I think exercises is something that needs a lot more research. It needs a lot more time to be taught, and it would be a dream of mine if APTA accreditation for entry level would put this in as a mandatory component, and preferably if they would do it tissue specifically, or at least with full attention to the need for individual dosed exercises. And I think it will happen. It's a question of time. As you said to Brandon, not too many people seem to be aware of the specificity of scientific therapeutic exercise progressions.
No, I think that's a really, really good point, Ola. And, you know, just to kind of take a little bit of a switch here, I couldn't help but noticing, you know, after kind of researching kind of what you've done and stuff, that you also work within the International Accrediting Commission for Physical Therapy Residencies. And I actually hadn't heard of this program. So, you know, for our listeners who are not aware of what this organization is, what does this organization do, and what have you learned from working within it?
As you know, I was a part of the foundation of iFounds. And in the last 10 years, I have tried to get iFound to seek some form of accreditation, some form of official approval. And instead of being a self-glorifying type of a private organization or a good old boys club, which it really represents today. So I have repeatedly tried to influence this unsuccessfully. Finally, I connected UNESCO, and you know, we have a lot of member countries around in the world, US being one of them, members of UNESCO, and they have a educational control system, and on the private sector, the control system for educational quality is called CHEA, the Commission of Higher Education Accreditation. Now, CHEA is the organization that, for example, APTA is accredited by. This is the accreditation that all universities throughout UNESCO is accredited through. Whether you go to Norway to a university or a private university in the US, CHEA is what approves of it. So I contacted CHEA. And I asked CHEA if we would have the same benefits as any other organization being accredited by them if we applied for this and went through the whole process. And they said certainly. And the benefits, what would they be? Well, a professional accreditation agency like what APTA is offering us in post-secondary education, they do not give us approval to teach with university hours or credits at universities. We do not get student loans, grants. We cannot apply for official grants like universities do. We cannot do student exchange programs, etc., 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 because it's a professional accreditation. Through CHEA, we will have all these plus more benefits with the same standard as any university. So we went through the application process with CHEA, and they gave us the permission to start accrediting the first 2 programs this year. So this is a brand new thing. Now, the fact is that we are going to, or not we, but this organization, which now is called International Accreditation Commission for Post-Professional Physical Therapy Programs, IACPPPTP. And this organization has changed name into this. And this organization is now looking for a couple of residency programs that is willing to go through to make sure that they are able to perform an optimal accreditation following international guidelines from CHEA. As soon as we have that, we will have all the benefits of a private university, way above and beyond what the APTA is offering today, way above and beyond what IFANT represents today, and we would have finally some kind of control over manual therapy. Today it doesn't even have a practice act. It doesn't. Anyone who takes a course is a manual therapist. And we want to develop this into something that later can be referred to as manual medicine. That's the purpose of the International Accrediting Commission.
Wow, it sounds like you guys have really accomplished a lot within the last few months trying to get accredited by that. Congratulations.
Yeah, right now this is a little moving a little slowly because CHEA has decided to change their guidelines again, and the new model for guidelines for program comes out in January. So we are kind of put a little on hold on that, but we do have the permission to start accrediting the first couple of programs and look forward to get that going in 2019. Hopefully then, after and expected lots of back and forths with CHEA, we will reach international accreditation sometimes in 2019 or 2020.
Well, Ola, this has been quite an amazing conversation. I've learned a lot just about the history of the profession and about different aspects of even present day things going on in the profession that I didn't know about. So I appreciate your insight, and I appreciate you coming on the show tonight. You know, we finish our interviews with a question that we ask all of our guests. So here's the question. If you could change one aspect of healthcare education, physiotherapy, or any other profession, which aspect would you change, and how would you change it?
I think the question entails my vision with this profession. If I should take just 2 minutes to address that, I would like to go back to where we came from. And, you know, Stephanie, this developed actually around 1800 in Sweden. And in Sweden, the people who did physical therapy, they were called gymnastic directors at the time. It came from exercises. And it entailed physical therapy, manual therapy, different kinds of modalities, and became so popular that it was actually competing with physicians. And this was before the history of orthopedics. So what happened after that was that the people who started this school, Per Henrik Ling and his students, one of the students was Kellgren, moved to London, where he continued this education. And one of his students, again, was the Syriacs, father of James Syriacs, And then, of course, James Syriax also learned from his father. And these guys were considered to be physicians. They were basically using physical therapy because they represented a kind of a threat to the popularity of medicine. The physicians in Sweden managed to close the school. James Syriax taught this lean concept that he had learned from his father and again came from Sweden. So the textbook, volume 1 of orthopedic medicine that he wrote, it introduced it as a so-called orthopedic medicine thing. He is considered to be the father of orthopedic medicine. He was an outstanding diagnostician and physician. The thing that he did, however, was to put the manual therapy, physical therapy combination from Ling and Kellgren into a different light. This came from generations of people in folks medicine, and James Syriax chose to refer to this from Hippocrates instead of Per Henrik Ling, who developed this concept in Sweden. Now, this was a history that was very well researched, and he was presented to IFANT as their official history. I think we owe James Syriax a lot. I studied with him myself, and I had the greatest admiration for him. But I think that we need to reestablish what we once were, what we once had. We should be the track today to get into all the things that osteopaths managed to do a few years ago when they entered into the medical profession. My vision, my goal for the profession of manual therapy is, as I said before tonight, to develop manual medicine for those who would be interested in having integrity and full control over their own profession. So much for my attention, for my participation. I really appreciated the opportunity.
No, we really appreciate it as well. I mean, that's just absolutely mind-blowing to me, just hearing all that and that history and stuff, because I frankly was not aware of that. And Ola, for our listeners perhaps who want to find out a little bit more about the Institute and kind of what you guys are doing, where can they find out more about you, either online or on social media?
www.olagrimsby.com. That has a lot of information on the website. We are on social media all over, and they can also contact me personally if they would like. And that could get up on the podcast with my email or whatever, but it would probably be better if they contacted the website, and that's where they find all the official information.
Well, very good. And for all the listeners who are kind of curious, just go ahead and feel free to check out the show notes below, and they'll be able to tell you everything that's in there. But, Ola, it's been a very, very fascinating and enlightening chat. I've definitely learned a lot from this chat, and I think that listeners have as well. Thank you so much for your service, your dedication. Best of luck with everything that you're working forward towards that mission.
Thank you, Brandon and Steph. Thank you so much. Very good questions. Thank you for having me. And also thank you so much for taking the initiative to do what you're doing with this. I think it's a fantastic idea.
Well, we appreciate that. We appreciate all the help and support we've gotten. And like you, we're on a mission as well.
So we are. Thank you.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.